Good afternoon, everyone. I'm Dr. Sinchana from Belgavi Institute of Medical Science. I'll be presenting the first case today. History given is 13-year-old male patient presented with a history of pain in the back of the neck since 1 year. One image was provided for this case. This is a scanner view showing multiple tissue fragments composed of bony tissue and soft tissue. On lower view, here we can see interlacing trabecula of oven bone, and stroma shows many blood vessels filled with RBCs. These two images are of high power view. Here we can see osteoblast lined along the trabecula of the oven bone, also referred to as osteoblastic rimming. These osteoblasts are plump. They are uniform in appearance, and they are arranged orderly in a single layer. This is a high power view showing highly vascularized stroma. This is a low power view and high power view showing various number of benign appearing giant cells. Other tissue bits showed areas of hemorrhage, fibroadipose tissue, and skeletal muscle fibers. There were no areas of necrosis, cytological atypia, or abnormal mitotic figures. To summarize, with the following microscopic findings, that is the presence of interlacing trabeculae of oven bone with osteoblastic rimming, and highly vascularized stroma, and with the presence of various number of benign appearing giant cells, and there were no areas of necrosis, cytological atypia, or abnormal mitotic figures. The differential diagnosis, that is osteoid osteoma and osteoblastoma. Because of the similarity of osteoid osteoma and osteoblastoma, distinction between them is difficult. So I'd like to know the CT MRI findings of this case. As these two lesions can be separated based on the size of the lesion, and also there will be presence of dense sclerotic bone in case of osteoid osteoma. And I would also like to know the clinical details of this case. That is the pain, whether it is excruciating type of pain, and thank you.
Thank you, Sinchana. A nice presentation indeed. As she mentioned, differential diagnosis of osteoid osteoma and osteoblastoma are true, correct. To arrive at the conclusive diagnosis, you require the history as well as the CT images or the radiological images, as Sinchana mentioned. So it was a 13-year-old male who presented with pain in the back of the neck since 1 year with difficulty in neck movement. And CT scan showed a focal expansor lytic lesion with sclerotic nidus in the spinous process of the C6 vertebra, and the lesion was more than 2.5 centimeters. This carries a significance here. And so, arriving at the images what she showed, we had irregular bony trabeculae lined by plump osteoblasts, and the intervening stroma was highly vascular, and it was composed only of fibrovascular tissue. There was no mitosis, necrosis, or any atypical features. So taking into consideration the clinical diagnosis, the radiological diagnosis, we arrived at the conclusive diagnosis of osteoblastoma because the lesion was more than 2.5 centimeter. If the same thing was less than 2.5 centimeter, then we would have called it as osteoid osteoma. Coming to the microscopy, they were it was a sharply defined circumscribed lesion with haphazard arrangement of bony trabeculae with lined by abundant plump osteoblasts. So coming to the discussion part, as you all know, there are two variants of osteoblastoma, the toxic and aggressive variants. The toxic has similar microscopic pictures. The only difference is in the clinical symptoms. They present with systemic symptoms like weight loss, fever, and night sweats. And this is the reason why they mimic malignancy. The second variant is aggressive osteoblastoma. Here we see epithelioid-like osteoblasts. So this can be confused with osteosarcoma. Here we need to keep the differentials in mind. ABC-like changes can also be seen in osteoblastoma, and it accounts for 16% of the cases. Differentials would be for aggressive osteoblastoma, as I have already mentioned, is this osteosarcoma. The difference is between you arrive at a diagnosis based on the malignant osteoid. If you see the malignant osteoid, you label it as osteosarcoma. Otherwise, it is aggressive osteoblastoma. The other TD, as Sinchana mentioned, is osteoid osteoma. The main differential feature is the size. The clinical symptoms and the microscopy most often overlap. So you have only two differential diagnoses for osteoblastoma, that is osteoid osteoma, and for aggressive osteoblastoma it is osteosarcoma. And a few of the DDs diagnosis what we received were telangiectatic osteosarcomas, which can be ruled out because of the absence of osteoid and the absence of large blood spaces. The others were hemangioma, angiosarcoma, but there was nothing suggestive of a vascular tumor. So our final diagnosis was osteoblastoma.
Myself, Dr. Megha Nayak from Karnataka Institute of Medical Science, Hubballi. The case given to us is case 2. It's a 25-year male with history of weakness of lower trunk and limbs in 6 months. This is the whole mount view.
On the screen, next slide. Yes.
This is the whole mount view showing on the extreme right side the regular arrangement of the chondrocyte. There is perichondrium, regular arrangement of the chondrocytes, the enchondral ossification, and it is continuous with the underlying bone. As we move towards the left side, there is increased thickness of the cartilage. There is irregular lobules of the cartilage, which is seen penetrating down into the underlying bone. This is a regular arrangement of the chondrocytes. There are 3 layers: perichondrium, the cartilage lobules, and the enchondral ossification and the underlying bone. This is the highly cellular area of the cartilage, showing irregular cartilage lobules. Another image of the highly cellular area. The cartilage has varied appearance. The topmost part showing dense hyaline matrix with clumped atypical chondrocytes, and the lower area showing the loose cartilage, the loose matrix with the closely packed large chondrocytes. This is another area of the area of the cartilage cap, where we see binucleate and multinucleated chondrocytes. This is another image showing the liquefaction of the matrix with binucleated and multinucleated chondrocytes. This is another image of the liquefactive chondromyxoid liquefaction. This image shows the cellular area showing nuclear atypia. The nucleus is hyperchromatic with prominent 1 to 2 nucleoli. This image shows bizarre chondrocytes within the lacunae having hyperchromatic to vesicular nuclei with prominent nucleoli.
here the marrow space shows increased vascularity. To summarize, this section study shows perichondrium, the lobules of hyaline cartilage with enchondral ossification. There is an area showing hypercellularity of the hyaline cartilage, which is arranged in irregular lobules, which is seen permeating into the marrow space. The chondrocytes vary in size and shape, showing nuclear pleomorphism. The nuclei are hypochromatic to vesicular, having 1 to 2 prominent nucleoli. There are binucleate and multinucleated chondrocytes with areas of matrix liquefaction. Vascularity of the marrow space is also increased. With these features, I would like to conclude my diagnosis as osteochondroma with secondary peripheral chondrosarcoma, grade 1. And since the patient presented with the features of lower trunk and lower limb weakness, it might be arising from the spine. And the malignant transformation in osteochondroma is 1% in solitary lesions and 5% in multiple osteochondromas. So the hereditary multiple exostosis also has to be considered. History and clinical findings and radiological investigation is necessary, and history of sudden increase in size and pain, and radiological investigation like the cartilage cap thickness, if it is more than 1.5 centimeters, points towards malignancy. Thank you.
Thank you. If anyone has a different opinion or diagnosis, you can please.
This whole thing should, whole screen should have only the presentation.
The Bluetooth device is ready to pair.
So, presentation. This was a 25-year-old patient who gave a history of lower trunk and lower limb weakness since 6 months, and clinical diagnosis was made as osteochondroma. There was a radiograph picture which showed tumor in the posterior end of the 5th rib in the paravertebral region, which was extending into the spinal canal. It was compressing the cord. This was the X-ray picture, but sorry, we don't have the CT findings. So we can see this lesion, which is quite large. So microscopically, what we can see is, very importantly, what we need to see in this case is, there is infiltration or permeation of the bony trabeculae with these irregularly shaped lobules of cartilage. So that is a clinching point here, because osteochondroma is a very close differential diagnosis to chondrosarcoma. So that is very important, because in osteochondroma, one is we need to see the thickness of the cartilage cap, and here the cartilage cap was more than 2.5 centimeter. Along with that, it is infiltrating into the spinal canal. So with all this, we made a diagnosis of grade 1 chondrosarcoma, conventional grade 1 chondrosarcoma. Here the atypia was not much, it was mild, and we did not see any mitosis. So cellularity was mild, not much. With this, we gave it as chondrosarcoma grade 1 conventional type. We received some of the diagnosis saying it could be chordoma and clear cell chondrosarcoma, but as well as osteochondroma. I already explained why it is not osteochondroma. Chordoma, we are not seeing physalliferous cells here, which are vacuolated cells, large cells, that is not seen in this case. So we ruled out chordoma. Clear cell chondrosarcoma also shows sheets of clear cells, cells with clear cytoplasm. So that is also not seen here. So the diagnosis goes as grade 1 chondrosarcoma conventional type. Next. So in chondrosarcoma, for prognosis, what is important is grading. So it is graded from 1 to 3, which is based on the nuclear size, the staining, cellularity, and mitosis. So here, one is moderately cellular, and as it goes to grade 3, it becomes highly cellular. And chromasia is maximum, it's more pleomorphic, atypical in the grade 3, whereas very mild pleomorphism is seen in grade 1. Mitosis is absent in grade 1, and plenty mitotic figures are seen in grade 3. So grade 1 is basically locally aggressive with a very good prognosis, having a survival rate of 83%, 5-year survival rate, whereas grade 2 and grade 3 carry much worse prognosis. Next case.
Good afternoon, everyone. I am Dr. Pankaj from second year postgraduate from JJM Medical College, Davangere. History was provided, 13-year male, pain and swelling in the left knee since 1 year. Other view I need.
Sorry?
Reader view I need.
From vector is it?
That is not correct. Vector view.
Another
That is
description.
Settings change.
this one.
No, not is that one. If you change, no, that will change in the view. Change that.
We can't do it.
The same thing is displayed there in the KCIAPM also. So we want a whole
It's
screen.
being broadcasted.
It's broadcasted live, no? So we want a whole screen to be only that one.
This is a scanner view showing the bone width of the tissues and with the surrounding lesions. This is no power showing the focal areas of immature bony trabeculae with surrounded by fibrous tissue, and that is composed of spindle cells. This is a high power of the same slide. This is another focus showing the fibrous tissue composed of spindle cells, and either side marrow elements are present. And this is another focus showing the open areas of mature bony trabeculae, and few areas showing the myxoid changes. This is another focus showing the focal area of mature bony trabeculae surrounded by fibrous tissue. This is the highest power. And this is another view showing the composed of both mature and immature bony trabeculae and surrounded by myxoid areas. This is high power of the same slide. This myxoid changes in the tissue, and few areas was showing the contrast changes. And this is the spindle cell arranged in the fascicles, and spindle cells are there which have some benign nucleus, and few spindle cells showed the eosinophilic cytoplasm. And this tissue shows the numerous blood vessels arranged in the staghorn pattern. This is the no power of the bone marrow elements around the fibrous tissue, and a few areas showing the focal areas of bony trabeculae. This is the highest power. Bone marrow elements are there. And coming to histomorphological findings, we considered it as non-neoplastic lesions composed of spindle cells and bony trabeculae, and few spindle cells arranged in internecine fascicles having benign nucleus. Few plump spindle cells also seen with eosinophilic cytoplasm, and few areas were showing myxoid changes, and mature and immature bony trabeculae surrounded by spindle cells, and hematopoietic elements are also there. Impression we made like in favor of non-neoplastic lesion with marrow elements. We can consider it as a chondromyxoid fibroma, but we need radiological coordination for the definitive diagnosis. Thank you.
Anybody else with a different diagnosis? Any differentials for this?
The Bluetooth device is ready to pair.
Thank you, Dr. Pankaj. So this was a case of 13-year-old boy who presented with pain and swelling in the knee since 1 year, and X-ray basically showed a lytic lesion in the proximal tibia. So this is the X-ray wherein we can see this lesion with a sclerotic margin. It is present in the epiphyseal region. So that is an important finding, lytic lesion in the epiphysis of long bone. And microscopy was, which Dr. Pankaj said as marrow elements. They are actually sheets of mononuclear polygonal cells. Okay, they were mononuclear polygonal cells having a very prominent cytoplasmic border. Nucleus being oval to round and having nuclear grooving. This grooving is again a characteristic finding, and along with these polygonal cells, we saw even the osteoclast giant cells which were scattered. So with this, so here we can see these polygonal cells, maybe the picture, I don't know if it was not very clear. See these, here can you see these cells? These are the sheets of polygonal cells which have the prominent borders. So with this, yeah, so we can see the giant cells here. So with this, we made a diagnosis of chondroblastoma. As Dr. Pankaj told, chondromyxoid fibroma is also a close DD. But in chondromyxoid fibroma, we need to see a lobular pattern, and the lobules having a hypocellular center and a hypercellular periphery. And there should be stellate or spindle-shaped cells in the myxoid background. That was not very evident here. So we ruled out chondromyxoid fibroma, and of course chondromyxoid fibroma arises in the metaphysis and not in the epiphysis. And the other diagnosis which we got was eosinophilic granuloma. So somebody had posted that. So it is not eosinophilic granuloma because of the background. So of course the Langerhans cell shows grooving of the nucleus. Background must have eosinophils, histiocytes. So it's a varied background which is not seen here. So this is chondroblastoma, is basically the tumor, benign chondroid producing neoplasm seen in skeletally immature patients. So it occurs most commonly in the long bones and particularly the epiphysis. And the most common symptom is pain, though swelling is rare, and they present as lesion which is sharply demarcated. So this is a microscopy which is characteristic of chondroblastoma, where you have these polygonal cells are the chondroblasts. And another important finding which may or may not be there in chondroblastoma is the chicken wire calcification. So here it's not very evident, but dystrophic, it's a dystrophic calcification which you see around the cells in the cell membrane, which is seen as a bluish discoloration on the cell. So that is again seen in chondroblastoma. And that thing is chondroid material.
Good afternoon, everyone. My name is Deepika. I'm second year postgraduate. I'm from KVG Medical College, Sulia. So this was our case. 29 years male, history of fall, followed by pain in left knee. So this was the picture. If you magnify this one, so we'll see there is a fibrous perichondrium and also one osteoid area. Below that, we can see there are chondrocytes, and here we can see some calcification also, which is like lace-like calcification. This area, this shows osteoid material. Below this osteoid area, we saw a diffuse sheets of chondrocytes. They look like chondrocytes. The lacuna having a dark nucleus. There was one area at this part which showed lace-like calcification, which is usually seen in chondroblastoma. But the chondrocytes, they were very benign, unlike chondroblastoma, where we see nuclear grooves. Here, there were no nuclear grooves, benign chondrocytes. And we also saw some fibrosis in one area. And there was also one area which showed myxoid change. As you can see, the high power of these chondrocytes, they have small, dark, regular nuclei. So even though lace-like chicken wire calcification is present here, but the chondrocytes don't have nuclear grooves, which is seen in chondroblastoma. And also it is diffuse, unlike chondroblastoma. And we got one area, that is this part, where we can see that the nucleus are a little bit hyperchromatic. So these features, we came to a diagnosis of chondroma and possibly periosteal chondroma. And our differential diagnosis were grade 1 chondrosarcoma and chondromatosis loose body. Basically chondrosarcoma, because it usually resembles grade 1 if it is low grade, it usually resembles benign tumor, that is chondroma. And because of increased cellularity, and also we got one area where there was hyperchromasia. We have a logical correlation and grade 1 chondrosarcoma. And chondroma, because uniform chondrocytes were there, dark regular nuclei, also myxoid changes, but myxoid change can be seen in chondrosarcoma.
Anybody else with a different?
Anybody will open. Doesn't matter, even if it's wrong. Let us. Any other diagnosis?
So this was a 29-year-old male patient who had history of fall, after which he developed pain, which was dull aching, aggravated on movement. And on examination, there was tenderness over the joint line. And important is the MRI finding. X-ray was normal, okay, and MRI showed a meniscal tear. So microscopically, what we saw was basically lobules of the cartilage, which was surrounded by the synovium. So this basically what we see here is crowding of the chondrocytes, and as Dr. Deepika told, this with this we made a diagnosis of synovial chondromatosis, secondary synovial. These chondromatosis, basically they can show mild nuclear atypia, and they can go for calcification and ossification also. And chondromatosis basically are of two types. One is the primary, which is a neoplastic one, and secondary. So secondary, it can occur in case of osteoarthritis and also in case of trauma, as in this case. So here it was secondary to trauma. So with this diagnosis of secondary synovial chondrosis was made, and in case of periosteal chondroma, basically we need to see an underlying cortex, which is not seen here. And there was another diagnosis which was given as fibrocartilaginous mesenchyma, but here we are not seeing any spindle cell trabeculate, so that is not a question. So the diagnosis is secondary synovial chondromatosis, secondary to trauma. Next.
Good afternoon. I'm Dr. Sushma from Mysore Medical College. and I'll be presenting a case file. Here, history given is 27 years old female patient complains of swelling over right ring finger since 10 years. And the slide shows tissue lined by periosteum. Underneath, we have a cartilage, which is hyaline cartilage, beneath which we have endochondral ossification and with mature bone. And we see in the cartilage chondrocytes which are benign. Chondrocytes, benign looking chondrocytes with single nucleus. And on the periphery, we have a proliferation of spindle cells. And these spindle cells are said that maturation of spindle cells leads to hyaline cartilage, and these are present in the intertrabecular spaces of the mature bone. And this is one of the characteristic feature of subungual extrososis. And one more DD we have is chondromyxofibrosarcoma and BPOP. To rule out both the things, subungual extrososis, we have a peripheral proliferation of spindle cells. We have peripheral proliferation of spindle cells with intertrabecular accumulation of spindle cells, loosely arranged spindle cells. BPOP, there will be spindle cells accumulation with the hyaline cartilage in the center. And whereas in case of chondromyxofibrosarcoma, the tumor will be multiloculated, and these lobules will be contain loosely arranged spindle cells. And to rule out periosteal chondroma, in periosteal chondroma, we doesn't see any spindle cells. And so my closed DD will be subungual extrososis followed by BPOP. Thank you.
Thank you, Dr. Sushma.
ಲ್ಯಾಪ್ಟಾಪ್ ಸ್ಕ್ರೀನ್ ಲೈವ್ ಮಾಡ್ಕೊಳ್ತಾ ನೋಡಿ. ಇವಾಗ ಸ್ಕ್ರೀನ್ ಎಲ್ಲ ದೊಡ್ಡ ಮಾಡ್ಕೊಳ್ಳಿ. ಇವಾಗ ಹಿಂಗೆ ಫಾರ್ವರ್ಡ್ ಇದೆಲ್ಲ ಇದು ಸ್ಕ್ರೀನ್ ಫುಲ್ ಬರೋಂಗ್ ಮಾಡೋಕ್ಕಾಗಲ್ಲ ಇದರಲ್ಲಿ. ಈ ಲ್ಯಾಪ್ಟಾಪಲ್ಲಿ ಫುಲ್ ಬರೋಂಗ್ ಮಾಡ್ಕೊಳ್ತಾರೆ. ಅಲ್ಲಲ್ಲ ಇಲ್ಲಿ ಇಲ್ಲ.
So this was a female, 27-year-old female patient who came with swelling and pain in the right ring finger. On examination, there was swelling and deformity, and the clinical diagnosis given was enchondroma. So microscopically, we see 3 layers, that is the perichondrium, the cartilage, and the bony trabeculae. And the diagnosis given was osteochondroma. The X-ray is not available here, and the differential is peripheral chondrosarcoma, but we did not consider it here. BPO, basically we need to separate spindle cells and the bone are arranged in a very haphazard manner, and with also the chondrocytes must be very bizarre. That was not seen here. And along with that, the bone should show a purplish blue mineralization called as blue bone, and that is also not evident here. And we gave a diagnosis of osteochondroma. It's again a benign cartilaginous neoplasm, which is very commonly seen in the long bones, but and very less commonly seen in the small bones. So metaphyseal region or the long bones are the predominant location, and small bones of the hand, as she mentioned, Nora's lesion, that is subungual exostosis, is seen, but this was not seen in the terminal phalanx. And these patients usually present with mass of hard mass of long duration, and this is generally about osteochondroma. As already told, we need to check out for the cap. This is just about the layers of osteochondroma, the 3 layers which we see here. So thank you. Next case.